Hello, everyone, and a warm welcome to today's THERA-Trainer webinar. My name is Frank Menzler. I'm the General Manager North America for THERA-Trainer, and I'm delighted to have you with us today for another exciting topic. First, a quick note for the audience. You're very welcome to submit your questions at any time during the webinar and using the chat or the Q&A function. We will collect all your questions and answer them after the presentation is finished. And before we begin, I would like to sincerely thank our partners at Burke Rehabilitation Hospital in White Plains, New York, for their collaboration and for sharing their outstanding clinical expertise with us today. We're honored to welcome an exceptional interdisciplinary team from Burke Rehab. We have Jessica Norton, the director of the Cardiopulmonary program. We have Allyson Sheehan, the clinical team leader for Cardiopulmonary Rehabilitation. We have Sandra Alexandrou, the vice president of Inpatient Rehabilitation. And we have Dr. Mooyeon, the senior vice president and chief medical officer of Burke Rehab. Thank you all for being with us today and for sharing your knowledge with us. Today's webinar is titled Exercise During Hemodialysis in the Inpatient Rehabilitation Setting, Implementation and Feasibility. Our speakers will provide a real-world overview of Burke's new and innovative hemodialysis program and demonstrate how coordinated interdisciplinary inpatient rehabilitation, including the use of the THERA-Trainer bemo in-bed motorized cycling trainer, enables early mobilization and meaningful exercise during hemodialysis. You will gain practical insights into clinical implementation, benefits, and operational feasibility in a very complex patient population. And with that, I'm very pleased to hand over to our team at Burke. Jessica, let's go.
Frank, thank you so much for that introduction, and thank you everyone for joining us today. So I'm going to dive right in. Let me change the slide. Okay, great. Here we are. So our learning objectives today include the following. We're going to delineate the benefits of inpatient rehabilitation services for the complex hemodialysis patient population. We're going to outline the challenges in bringing in-center hemodialysis to a freestanding inpatient rehabilitation facility. Talk about establishing hospital operations and procedures to successfully serve the hemodialysis patient needs on a weekly basis, including providing hemodialysis treatment sessions, as well as 900 minutes of therapy each week, which includes intradialytic exercise. We're also going to discuss the challenges encountered during the implementation and sustainability of intradialytic exercise in the inpatient rehabilitation setting. And finally, we will discuss patient receptivity and feedback via survey results to completing intradialytic exercise during their stay in the inpatient rehabilitation setting. Might just be a slight delay in the slides changing, so my apologies. Okay, great. So the gold standard for treatment of those individuals with end-stage renal disease is kidney transplantation. It's often known to have better survival rates and quality of life for those candidates who do receive a kidney transplant. However, organs are a scarce resource. Dialysis is then used for that life-saving treatment for the end-stage renal population. We want to provide a very brief overview of the two types of dialysis and the settings for dialysis delivery. There are two types of dialysis, hemodialysis and peritoneal dialysis. And there are four typical settings for dialysis delivery. We have in-center, in which patients will travel to an outpatient clinic, typically 3 times per week. There's also in-home, which is using peritoneal dialysis. This is less common, but does offer flexibility to the patient. And there's also in-hospital setting, which is for those patients who might develop a need for acute dialysis, or for those individuals who are already hospitalized but have an established chronic dialysis need. And finally, the fourth setting is in the post-acute care setting, for those individuals who are admitted to a SNF setting. They might have already limited rehabilitation needs, and again, the dialysis could be on site at the SNF, or they may need to travel to an outpatient clinic from the SNF setting. The hallmarks of end-stage renal disease is a lack of physical activity, especially in those individuals who need to receive dialysis 3 times per week. This lack of physical activity leads to more sedentarism, fatigue, and decreased physical function, as well as poor quality of life. Individuals living with end-stage renal disease have significant medical and functional limitations, which are predictive of poor health, rehabilitation, and psychosocial outcomes. These significant medical needs and a decline in functional status result in an increased risk of mortality, institutionalized care, and disability for this population. The next 3 slides are from the U.S. Renal Data System's 2024 annual report, which is highlighting the increased risk of mortality, higher hospital readmission rates, and total days in institutionalized care for the end-stage renal disease person. So this table shows the expected remaining lifetime for someone with end-stage renal disease. The table illustrates a markedly foreshortened projected lifespan for those who have end-stage renal disease compared to those who do not. For example, in the table, the individuals that are aged 40 to 44, there is an over 25-year projected lifespan difference between men receiving dialysis, approximately 10.9 years, and men in the general population expect to live 36.5 more years. So that's a very large difference already. And the difference for women in that same age group is greater than 30 years as well. This table shows the percentage of hospital discharges and hospital readmission rates within 30 days for the end-stage renal disease population. The table illustrates a higher percentage of hospital readmissions for those individuals receiving hemodialysis and peritoneal dialysis as compared to those who are post-kidney transplant. Among individuals receiving hemodialysis and peritoneal dialysis in 2021, the percentage of readmission rate was slightly higher in those as compared to recipients who have a kidney transplant only. And you have relative in 2022 versus 2021, the percentage of readmission decreased for those receiving dialysis, but was virtually identical for those individuals with a kidney transplant. And finally, this last table shows the adjusted number of hospital days per year per person for those with end-stage renal disease. The table shows that these individuals post-kidney transplant will spend approximately half as many days in the hospital setting, so about 5 days per year, as compared to those who are receiving dialysis, which is approximately 9.5 days per year. So now I'm going to turn it over to Allyson, and I'm just going to turn you around real fast.
All right, thank you, Jess. Okay, so individuals living with end-stage renal disease receiving hemodialysis face a complex mix of physical, psychosocial, and practical challenges to managing their health condition. Strict adherence to dietary and fluid restrictions, along with avoiding foods high in potassium, phosphorus, and sodium, while making sure they get enough protein, are all very important. Polypharmacy and potential undesirable medication side effects can result in difficulty adhering to prescription regimens. Hemodialysis is very time-consuming. Typically, outpatient dialysis centers schedule appointments 3 days per week, and sessions can last 3 to 5 hours each, not to mention travel times, waiting room times, and recovery time after receiving intervention. These individuals are prone to sedentary lifestyles due to the cycle of fatigue and practicality of executing their demanding schedules, not to mention balancing the impact of their medical condition with their usual activities of daily living, work, and social activities. Getting to and from dialysis and medical appointments, lost income or possibly loss of employment, and potential need for caregiver assistance are all confounding variables as well, especially in rural and underserved areas. Finding care providers to bridge the gaps and assist in coordinating care following an acute hospitalization or due to a change in functional status can leave these individuals at risks for disruption in care and increase their risk of those poor health outcomes Jessica just mentioned earlier. It is well documented in the literature that these individuals demonstrate decreased physical capacity compared to age-matched individuals, impacting them across domains. Where physical activity used to be avoided in this patient population, there is now a wealth of evidence stating that individuals with end-stage renal disease receiving renal replacement therapy benefit positively from a coordinated multidisciplinary team approach in the rehabilitative setting. Furthermore, physical rehabilitative services delivered in the inpatient rehab setting have been shown to mitigate the negative sequelae associated with end-stage renal disease. Successful participation has been shown to be feasible and results in improved functional independence outcomes with decreased caregiver burden, increased rates of community discharges as compared to prolonged institutionalized care, and lower mortality rates 1 year after discharge.
Okay.
And that, yeah.
Yeah, okay. And my name is Mooyeon. I'm a Chief Medical Officer at Burke Rehabilitation Hospital. First of all, I really want to thank Frank, Jessica, Jess, and Sandra. And putting together, idea is one thing, but implementing this in such a successful manner is a whole different science and art. So I'm really, honored to be a part of this project. So the one I want, before we talk about hemodialysis and implementation of exercise program during hemodialysis, I want to tell you a little bit about who is Burke. So Burke is acute inpatient rehabilitation, and we are one of the largest freestanding rehab hospital in New York State. We are just above New York City, White Plains town, New York, White Plains, which is Westchester County. And just in the context of this hemodialysis, there are a lot of these are very special population, and they have high medical care need. At the same time, their need for rehabilitation is also high. So those two patients' needs are often very hard to match, because currently at that time when before we put the hemodialysis program together, very little places in-house the hemodialysis was possible, at the same time providing a high intensity rehabilitation program. So this is just showing our beautiful campus, and please, if you get a chance, visit us. Yeah, so we did some data analysis. So how many patients are actually, referred to us who is requiring hemodialysis for acute inpatient rehabilitation? It turned out that quite a lot. We have 150-bed hospital. Maybe, at a given time, we have 80 to 100 people referred at a, in the screening pool, and 2-3 patients a week were actually referred to us, but requiring hemodialysis. So before we put this program together, we had no choice but to turn those patients down and, advise them to go other places, such as more subacute, less intensive setting of rehabilitation. So basically, this whole program was really to answer and address the patient needs and their need and the family's need. Yes, so the whole administration, from our CEO and even the region, we belong to a multi-payer system, and decided to make this as a strategic goal, one of the things we want to accomplish. That was a really important step. And then we had to define many things. Number one is a population. What kind of patient population? Are these patients who have established hemodialysis, or somebody who just started hemodialysis because of acute kidney failure? So initially we were in theoretical, in theory, we said, oh, it will be easier, and then maybe it's starting with the people who has established chronic kidney disease and then the hemodialysis. However, in reality, the people who needed these service, acute rehabilitation and the hemodialysis, was actually the latter. The people who had a normal kidney, but they went through a sepsis or some kind of a acute other illnesses, led to hemodialysis treatment, but some of them really, they were new, right? So those are the people who actually needed also rehab. So at the end of the day, we had lots of patients in that category, and some of the patients, after successfully recovering their underlying medical illness, they were able to come out of the hemodialysis as well. So this was really a rewarding experience. The second thing we had to set up was a care model of hemodialysis. So we had a choice of developing our own within, our nurses and training, but we chose more effective and efficient way by partnering with Fresenius, the company, and then that really resulted in synergistic implementation and benefit from both mutually. So the third one was education, and especially the nursing and the therapy and the physicians about the hemodialysis being the highest risk category of the procedure by the Joint Commission, because anything can happen, and infusing certain fluid and going through this process is really at great risk. So we had to set up a whole failure mode analysis for every single thing, what each step of from the screening the patients all the way to the discharge. So those are very important matters, which include also we needed a medical director of a hemodialysis service, which we, that person we didn't have, but with the collaboration with our sister hospitals, we were able to secure that. So lots of things, but basically that was the foundation of the program to start. Yeah, thank you.
Sandra will be speaking next.
Hello, everybody. Thank you for joining us. So when implementing this program, hemodialysis program at Burke, we had to really look intently at the daily operations to make sure that we met the needs of those patients receiving hemodialysis at Burke. So we had to implement a screening process at Burke for these patients. We had to make sure that we obtained all the critical clinical information about these patients, their current hemodialysis program and their schedule. So we decided that for patients receiving hemodialysis at Burke, they would be on a Monday, Wednesday, Friday schedule. Some patients refer to us who are on a different schedule, but when they came to Burke, we transitioned them to the Monday, Wednesday, Friday schedule. It's been very successful. Those patients who are new to hemodialysis when they came to Burke and those who have been on an established community program are both can both be accepted to Burke to continue their rehabilitation needs. Initially, the patients accepted to Burke in need of hemodialysis were admitted to the cardiopulmonary program. But over time, we expanded the admission of these patients to other programs and looking at a variety of admitting diagnoses. As long as the patient had a rehabilitation admitting diagnosis and were on hemodialysis and met the other criteria for admission, they were accepted. Some other diagnoses included spinal cord injury, amputation, and as well as cardiopulmonary diagnosis. Operationally, we had to look at how we could ensure that the patients receive their hemodialysis as scheduled Monday, Wednesday, Friday, but in addition to ensure that they were also able to attend all therapy that was scheduled, as this, attending therapy is the primary reason for the patient's admission. It's too fast on the trigger. There we go. So in looking at the patients who are referred to Burke for admission, we had to make sure that they met the qualifying criteria to be admitted to a facility like Burke, which is an inpatient acute rehabilitation setting. So they had to meet the criteria for Centers for Medicare and Medicaid regulatory admission criteria. And so there are a few. First is that the medical necessity requires ongoing medical management and supervision by a rehabilitation physician, that they're able to participate in intensive therapy services, which includes participating in 3 hours of therapy over a 5 to 6 day period, that they require at least 2 of the 3 therapy disciplines, PT, OT, and speech, but one of them must be physical therapy. Each week, the patients must receive 900 minutes of therapy. That's 15 hours of therapy. And this is required in order for them to meet the compliance standards that are established in this type of setting. We have certainly, as an institution, identified some challenges for patients on hemodialysis and their ability to actively participate in therapy in this type of setting. So again, even though patients are coming to us on hemodialysis, they have to meet the requirements for the for admission in this type of environment, as do all patients, regardless of whether or not they need hemodialysis or not. So again, the appropriate rehabilitation diagnosis for admission is important. They have to be able to actively participate in 900 minutes of therapy each week. And this required a lot of staff education as well as training. Dr. Opark mentioned, that required this type of intervention for therapy, nursing, and the physicians. As an organization, we had to make sure that we would be able to manage the medical complexities of this patient population. So oftentimes these patients admitted to Burke needing hemodialysis come along with some other comorbid conditions in addition to their primary diagnosis. And that includes diabetes, peripheral vascular disease, coronary artery disease, peripheral neuropathy, stroke, osteoporosis, degenerative joint disease, and they also are at risk for fractures. Most of these patients, I would say all these patients, require follow-up appointments with other providers during their stay here at Burke. So we had to make sure that we created a system that was flexible enough to allow them to receive hemodialysis 3 times a week and also actively participate in their therapy. If the access site became compromised and that impeded their ability to receive their hemodialysis here at Burke, we did develop a contingency plan, which required that the patients be transferred to White Plains Hospital for hemodialysis. White Plains Hospital is about 2 miles from Burke. As with all patients at Burke, discharge planning requires a collaborative interdisciplinary team approach. We want to make sure that we're meeting the needs of these patients on hemodialysis and set up appointments for them to allow them a seamless transition from receiving hemodialysis at Burke to a community provider. I will now transition the presentation to Ally.
Thank you. So as mentioned earlier, Burke is a 5-unit, 150-bed freestanding inpatient rehabilitation hospital. Slide will not change, forward to the next one. But at this time, patients requiring hemodialysis can be admitted to any one of our 5 programs based on their primary rehabilitative diagnosis and clinical needs to make sure that the staff working with them is fully equipped. 3 rooms on the cardiopulmonary floor have been renovated and equipped to be compatible with the equipment necessary to deliver hemodialysis intervention. 2 of those rooms are double occupancy and 1 is a single occupancy to assist with isolation and infection control measures when warranted. Patients are transported from their rooms on their respective home unit in their hospital bed to one of the 5 designated dialysis beds. We typically have 2 shifts of treatment or intervention start times, 11 a.m. and 3 p.m. Hemodialysis treatment times and therapy schedules are set via a collaborative effort, a constant communication stream between Burke's nursing team, Fresenius, and the inpatient therapy scheduling team. There's consideration for how many patients are admitted at any one time, the medical complexity of those patients, and the unique needs of each individual that they may have. So for example, any offsite medical appointments or follow-ups, social work coordination with community resources, or family training needs, to name a few. Given fluctuations in the volume of patients requiring this service, we have recognized the need for a certain level of flexibility. So for example, if the census is at or near 10 patients receiving hemodialysis, we have to add in a 3rd shift, typically starting at 8 a.m. However, this adds a significant difficulty in managing the patient's schedule for therapy and ensuring that each patient is achieving that baseline goal of 3 hours of therapy per day, as per our inpatient rehab facility requirements that Sandra spoke about. And I'll try to talk a little bit more about that in the next slides. Before we get into that, just so you can kind of visualize our space, these are the right and left sides of one of our inpatient hemodialysis treatment rooms with the dialysis equipment set up. And then on the nursing unit, former office spaces were renovated and repurposed to store any of the dialysis utility needs. Our dialysis partner Fresenius manages these rooms. Okay, so as mentioned, all patients admitted to Burke, including those receiving hemodialysis treatment, are scheduled for 900 minutes of therapy in a 7-day window, starting on their day of admission. This typically works out to 180 minutes in a given day, and the majority of therapy is delivered Monday through Friday. Constant communication between Fresenius and Burke is critical to maintaining this workflow and ensuring we are maintaining compliance with this standard. The day prior to dialysis, so Sunday, Wednesday, and Thursday, Burke's nursing team communicates the census of patients requiring treatment and any unique needs that should be considered when scheduling. Fresenius confirms the number of staff and shifts that will be required based on that information. And the AVP of rehab and scheduling coordinators at Burke create and manage the therapy schedule for these patients with feedback from the primary treating clinicians. In the beginning stages, and due to the novelty of this treatment intervention in this medically complex patient population, we were more conservative, not mobilizing patients after dialysis and not performing intradialytic exercise. So as you can imagine, we were hitting a deficit where patients on hemodialysis treatment were not meeting that 180 minutes of therapy on treatment days. So to account for this, we were scheduling extra therapy sessions on non-dialysis days, so Tuesday, Thursday, Saturday, and Sunday, to meet their inpatient rehab requirements. Fatigue and activity tolerance was a huge barrier to care delivery with this model, with this population. So more than 3 hours of therapy in any given day was a huge challenge for these patients, and we felt we could be doing a better job. Intradialytic exercise was identified as a potential solution to this problem to provide meaningful therapeutic intervention, enhancing the hemodialysis treatment and improving the patient experience, as well as assist us with helping these patients meet their 900 minutes of required therapy each week. This is just a visual of that workflow that I just described to help streamline the decision-making process for our non-clinical staff. And then this next slide is just a screenshot from a patient's chart. It's one of the methods that we use to track their therapy minutes to see where minutes may be missed, seeing the rationale for why minutes may have been missed, and so on, so that we can really troubleshoot and try to maximize the patient's time here. So this patient example was actually a good one where we met and even exceeded the requirements for patient care delivery. And typically that's because this patient had the opportunity to perform intradialytic exercise using the bemo and got extra therapy on those non-dialysis days. Okay, so turn the computer back around.
Our apologies for any technical difficulties. I hope nobody is getting dizzy with the turning. But again, thank you for your patience. So let's now talk about providing intradialytic exercise here at Burke. Quickly, a definition of intradialytic exercise refers to physical activities that can be performed during hemodialysis treatments. The typical types of exercise that can be completed during hemodialysis can include aerobic exercise, resistive or strength training, as well as stretching. From the UK Renal Association, they recommend that intradialytic exercise be available in all units as a treatment for enhancing physical function in those individuals who don't have contraindications. They also further suggest that intradialytic exercise can be considered as a method of enhancing, again, the person's quality of life. They also suggest that intradialytic exercise regimes should be devised and supervised by appropriately trained staff, such as physical therapists or exercise physiologists, and so forth. Intradialytic exercise is considered safe and it offers higher adherence rates compared to exercise as performed outside of dialysis sessions. There are also physiological benefits provided, including reduced fatigue levels, improved quality of sleep, increased exercise tolerance overall, and enhanced quality of life. The research also indicates that intradialytic exercise can also improve the overall efficiency of the dialysis treatment itself, reduce systemic inflammation, as well as improve bone mineral density. At Burke, we chose to utilize the THERA-Trainer bemo device to provide aerobic exercise to our typical patient population here. This type of exercise has been found to be beneficial for those patients who present with significant weakness and deconditioning overall post-acute care hospitalizations, which we often see at Burke. Additionally, to maintain the integrity of the vascular sites needed for hemodialysis, we collaborated with Burke's medical and nursing providers and chose to provide just lower body cycling during dialysis treatments. All right, so this is the THERA-Trainer bemo. It is a robotic assisted in-bed cycling trainer for early mobilization in the hospital setting for both the upper body and the lower body. Change the slide now. Give me a moment. I'm just going to play a video of the bemo here. Okay, looks like we are in action. There's no sound on this video on purpose, but the bemo really has been a great tool for us here at Burke with our dialysis patients. It's been easy to set up over the patient's bed in one of our designated hemodialysis rooms at Burke. Overall, we've heard anecdotally from the hemodialysis patients that they've enjoyed using the bemo. It offers, often a positive distraction from the dialysis treatment that's going on. It allows them to another opportunity to really work towards their physical function, again, while being on dialysis. And again, when providing intradialytic exercise here at Burke, we're completing lower body cycling just so that we really don't affect that vascular access site that's needed on the patient's upper body for hemodialysis. Okay, looks like the video has wrapped up. Let me try to change slides here. Okay, so the THERA-Trainer team provided on-site training to us at Burke in November last year to a few members of our cardiopulmonary therapy team when we first received the bemo. Allie and I both went through this training process, as well as another OT and PT from our therapy team who wanted to be those champions and help facilitate the train-the-trainer model. After we did this on-site training with THERA-Trainer, then we worked on strategically training all of the cardiopulmonary therapists, so PTs and OTs, as well as our rehabilitation aides on our program to really get that hands-on practice with patients and to start utilizing the bemo more and more. And then we did have the THERA-Trainer team come back to Burke in February of earlier this year to provide additional on-site training to basically OT and PT teams on all 4 other programs that we have here at Burke in our inpatient setting, so we could have 2 champions from every program as well to start facilitating the use of the bemo across programs as we had more and more patients with hemodialysis needs getting admitted to all programs. Oh, great. All right, it changed for me already. Next slide. So here is a photo of one of our recent patients at Burke. She really enjoyed using the bemo during both of her admissions with us and was happy to participate in a photo shoot, which was a great opportunity for her. Okay, let me change slides. So we want to share some data about using the bemo here for intradialytic exercise at Burke. So we collected this data is just from the end of November last year through mid-September of this year. We had 27 patients with hemodialysis needs use the bemo during their dialysis sessions. Overall, we provided 89 bemo sessions to those patients. Patients received between 1 to 9 sessions with the bemo. So it was a big variety, and some patients received multiple sessions, some just receiving 1. But the most important thing I think that we saw with this effort and use was that we provided 4,590 minutes of therapy minutes to these 27 patients during their dialysis session. So again, with the bemo, we really could see that we could provide meaningful therapy minutes to those dialysis patients where we would have previously missed that opportunity when we didn't have the BMO to actually provide these meaningful therapy minutes to them during their dialysis treatments. And of course, we've experienced some challenges with implementing the BMO. You know, there are scheduling changes that occur when dialysis patients may need to be moved from a morning session to an afternoon session or vice versa, based on the dialysis shift needs from Fresenius and just the staffing complement. Having only one device available, of course, in the hospital creates limitations when we do have a lot of dialysis patients admitted. We've been in the double digits a few times, so that has been a different kind of challenge for us with having only one device. BMO sessions are certainly patient volume dependent. We can schedule about 3 BMO sessions a day, typically at 11:30, 1:30, and 3:30 based on the structure of when dialysis is provided by the Fresenius team and our therapy staff schedule. And there are also infection control considerations. We can't use bleach wipes on the device just per the manufacturer guidelines. So we're not taking the BMO into rooms where patients might be under isolation precautions for C. diff or norovirus. But when these patients are off of those precautions and lifted, we'll then go ahead and be able to continue the therapy with them using the BMO if they're an appropriate candidate. But again, just one other consideration when we're thinking about appropriate patients. Okay, so I've changed the slide hopefully and turn you guys back around to Allie.
Thank you. All right. Very good. All right. So since our program launched, like Jess was saying, we've discharged 108 patients with the average length of stay of 16.6 days. This is, kind of right on par with our average hospital-wide for 14 days for all diagnoses. So we're happy with that. The majority of them, 65%, were discharged to home. The graph on the left just shows you a breakdown percentage-wise by diagnostic group. So the diagnoses that qualified them for admission for inpatient rehabilitation, the majority of which were orthopedic, cardiac, and other debility. The table on the right just shows a numerical breakdown of those 108 patients. Okay, so this graph just shows the quarterly trends in our census. So since program initiation, the number of patients on dialysis has been pretty consistent and holding steady. So there's definitely a consistent need for acute inpatient rehabilitation services in this patient population. This slide shows the quarterly trends in outcomes and discharges, so average length of stay. We're always interested in performance improvement and making sure we are not only delivering effective care, but also being efficient with the utilization of healthcare resources. So since the launch of our program, we have learned a lot in terms of the needs and variables that impact the discharge planning process. Initially, patients receiving hemodialysis had slightly longer length of stays. We've reduced that to be very similar, like I said, to our hospital's average length of stay for all patient diagnostic groups. This really speaks to the efforts of the interdisciplinary team members involved, clinical and non-clinical, from learning how to maximize their participation in therapy, making up missed therapy sessions, and identifying or finding solutions to the barriers these patients face in the community. So connecting them with resources, establishing comprehensive plans to get patients home and back to their lives sooner. Like I've mentioned, our focus is always to discharge people back to the community, getting people home. However, with such a medically complex and diverse patient population, that's not always possible. This slide shows the quarterly trend in discharge destination, including acute care transfers. Some common reasons for acute care transfers are typically graft site failure, complications, or sepsis. Some patients have significant barriers to home, whether it's lack of social support, inability to transport to and from dialysis center 3 times a week, medical fragility, so they just can't tolerate getting out into the community. Some of those variables are just outside of our control, so that's kind of where our discharge to subacute factors in. But as much as we can, we're incorporating family training early, identifying those potential needs, so ways to improve accessibility in and out of their home, even accessing charity funds to make those home modifications and get the equipment people need in their homes. Those are all strategies that we've utilized to help get our patients back in the community, back to their homes. And I'm going to turn that back over to Jess.
Okay, so this is what our last slide about Burke's outcomes and discharge for our patients for the hemodialysis program. So this slide is really highlighting our efforts to really maximize the hemodialysis patient population's participation in therapy and their functional outcomes. So the graph on the left side shows the average amount of missed therapy minutes by quarter. So from the start of the dialysis program in March of 2024, we've seen a fairly steady downward trajectory with the amount of average missed minutes for these patients due to our combined efforts to maximize those meaningful therapy opportunities with the additional therapy on non-dialysis days, as well as adding the bemo in for interdialytic exercise. And then on the right-hand side, you're going to see that we have an average change in functional score per day, per quarter. So we now see a fairly steady upward climb in the average change of the hemodialysis patients' functional scores, which is great because we want our patients here to improve and to really be able to get back to their lives and improve their quality of life. And it looks like these patients are starting to really benefit from the intensity of rehabilitation services here in the IRF setting at Burke, and hopefully also in the larger realm of the IRF setting. So we're going to talk a few minutes just about future directions as well as our hemodialysis survey that we're started here at Burke. So the last year and a half has really been both busy and rewarding for our dialysis program. It's really been exciting to work on also implementing the bemo device into our dialysis program for the last like 11 months now at this point. At this time, we're working towards really refining our day-to-day operations for the dialysis program, which again is maximizing those 900 minutes of therapy every week, looking at more quickly identifying appropriate patients to use the bemo, refining our scheduling process to continue to maximize those opportunities for intradialytic exercise, and then also, looking at the possibility, do we need a second bemo device to help expand this program further? And in order to, to really obtain meaningful feedback from our dialysis patients here, we've recently developed a patient experience survey earlier this summer. We started to offer the survey to our dialysis patients in early September, and we're going to share a little more in the next few slides about just the survey itself. And again, a little bit next layer on from this is a future organizational level efforts for the dialysis program. Right now we're waiting. We're going through an IRB approval process, hopefully to create an institution-wide database for the dialysis program, because we really want to, look at contributing to the current available evidence and literature, and hopefully do a retrospective study about hemodialysis patients in the IRF setting. So more to come on that hopefully soon. All right, just try and change slides here. Great. So like I mentioned before, we're going to turn our attention now to our newly initiated dialysis patient satisfaction survey at Burke. We began offering this survey again around the first week of September earlier this year. A member of our cardiopulmonary therapy team completes weekly check-ins with any in-house hemodialysis patients who are approaching discharge. The survey is offered to the patient typically during their last week of their admission. This team member provides education on the purpose of the survey and just how to access it for the patient. The survey is available electronically using a QR code by either the person using their own smartphone or a tablet device. The survey is anonymous and voluntary, of course. If the hemodialysis patient doesn't have access to their own type of smart device, then we provide them with a Burke tablet that they can use for a few moments to complete the survey. And the survey does really cover various aspects of the hemodialysis patient's experience at Burke. So that includes things like dietary needs, pain management, opportunities for interdialytic exercise, the discharge planning process, and so forth. And from what we're going to share to the next couple slides, the initial results of our survey, as of the end of October this year, we had about 12 patients complete the survey, and they had a generally positive response so far from them about their overall experience at Burke, which is nice to hear, and more data certainly needs to be collected. Okay, so this is just some visuals of what the survey itself looks like, what some of the questions are like in regards to the patient's experience here at Burke. Slides again. So the next couple of questions here are about dietary needs as well as transportation. to the patient's specific dialysis treatment room. So again, because some of our patients are sleeping, for example, on the brain injury unit on the second floor, they have to be transported down from the second floor to the first floor for one of the 3 designated dialysis rooms on the cardiopulmonary program. There's a couple questions here about if the patient did have the opportunity to use the bemo device for intradialytic exercise. We have a couple questions in the survey, just asking them specifically about what their experience was like with the bemo, if they felt like it was beneficial for them. And we also included a few questions about, what the patient's experience was like with working with an interdisciplinary team, how we worked together, how the patient themselves felt incorporated as a part of that team, just about that whole, process of being here with us at Burke. And then we also had some opportunities too for the dialysis patient to provide some personal and more individualized feedback to us, have some free text options for answers so they can provide us with feedback or suggestions on how we might improve things for the dialysis program and for future patients. All right, so in summary, we've really learned again so much over the last 1.5 years with our dialysis program at Burke. We've seen how this complex patient population has been benefiting from the interdisciplinary approach in the IRF setting. We've made strides to implement, and we want to continue to expand upon our innovative approach with providing intradialytic exercise for the hemodialysis patients with the tool of the bemo device from THERA-Trainer. And we've also been, we know that providing hemodialysis at Burke just in general was a big lift. So we know that how much of that experience has already required ongoing teamwork and collaboration, and it's only going to continue. We need to, keep looking at how we've already redesigned our hospital's operations and procedures to bring dialysis on site, to a freestanding IRF like this, and how we can continue to improve upon it. Because again, we've been in a big learning curve since we started this, and there's more that we can do and learn and change together. And again, we've also been navigating these challenges that we've experienced just with really starting and implementing a new intradialytic exercise program. And really, again, really includes that interdisciplinary and collaborative team approach to be successful and to really see it come to more fruition. So we wanted to thank everybody so much for attending our presentation today. We really appreciate it. And let's see if we have any questions or anyone has any comments. We're happy to spend a few minutes doing that now.
Well, thank you very much, Dr. Park, Sandra, Jessica, Allyson, for your wonderful presentation and for all your experiences presented today. And yes, indeed, we have a couple of questions already. And one of the first questions was, how did the patients feel mentally and cognitively after exercising on bemo on the hemodialysis? Did you see any changes there?
That's a great question. I'm just bringing you guys closer so Allie and I can both answer these questions potentially together. I mean, overall, we have to constantly monitor our patients during their exercise on the bemo. So we always are monitoring their vital signs, using the Burke scales for rating of perceived exertion and dyspnea to really, see if we're challenging our patients appropriately and that they're tolerating it well. Do you want to add a little bit more?
A lot of patients enjoy the bemo because otherwise they would just be laying in their hospital bed for 4 hours, kind of just listening to the machine. So it gives them a distraction. It gives them something to engage in physically. They find that rewarding that they were able to do something with that time and not just lay in their bed. So yeah, I think overall they do find it very rewarding in that sense, and they are typically very engaged with it, and having the therapist there with them for that treatment time as well also gives them some benefit.
Thank you. That's probably a good kind of carryover into the next question. Is actually, who does the patient setup and the patient monitoring during the exercise for the bemo? Is it the nursing staff? Is it the PT? Who is that?
Yeah, great question. Yeah, good question. Currently, we have when they're using the bemo THERA-Trainer, they are scheduled with either an occupational therapist or a physical therapist. That therapist will also have a rehab aide assigned with them to help with transporting the bemo setup and breakdown. The therapist is ultimately responsible for monitoring them while they are exercising. So monitoring blood pressure, like Jess mentioned, their rating of perceived exertion and dyspnea. But there is also a hemodialysis nurse that is constantly present monitoring the hemodialysis separately. So the therapist isn't monitoring the hemodialysis. The therapist is just monitoring the patient's tolerance to the activity.
Okay, thank you. Then there was another question is, what is roughly the percentage of patients which is fit enough to exercise during hemolysis in your program?
Oh, that's a good question.
That's a good question. It's a good number that we have to look at in terms of, because we don't offer the BMO to every patient on receiving hemodialysis, because like we mentioned, there's such a heterogeneous group. So we could have patients with lower extremity amputation, or just not cognitively intact enough to tolerate. So it would be good for us to actually crunch that number and see the number that we offer it to the number that do engage in it. But like Jess had mentioned, we get looking at the number of minutes that we've been able to capture. We have captured a nice chunk of patients, but looking at that percentage of who we offer it to versus who actually engages would be a good number to look at.
Yeah, because I guess with our numbers that we shared in the presentation, we had 27 patients participate in the BMO out of 108. So you're looking at a little under like 25% of the patients. But it is so individualized because we really do have to look at if the patients are appropriate for the device from a variety of reasons. And often we collaborate too with the medical team. If we do have questions about medical fragility, if they are like able to participate during dialysis itself, or sometimes too with the different diagnoses that are coming in here, sometimes someone with a behavioral presentation after a new traumatic brain injury wouldn't be appropriate to be cycling on the BMO device because of behavioral presentation. So it really is individualized, but hopefully we'll get our IRB approval in the near future because we really need that database to really be able to look at the numbers. We've been doing a lot of this manually right now, so it'd be great when we have a little more systematic approach to this and really be able to look at that. But it's a great question because we're hoping also to look at that and and really write about this and put something out into the literature that could be helpful for the the greater public to have that information available to them.
And then there was a question, it's more probably a clarification. Do you have exercise during hemodialysis or just between hemodialysis session?
Oh, so we have a variety here. So our patients who are here for inpatient rehabilitation have to have 900 minutes of therapy every week. So they are definitely exercising outside of dialysis sessions, but we also added the BMO to complement what these patients need to receive enough therapy minutes almost every day of the week, essentially, because they really are receiving therapy nearly 7 days a week in order to maximize the amount of minutes they can have of therapy and still also have their dialysis treatment. So the BMO itself is being used for intradialytic exercise. So during dialysis, during the active treatment of dialysis, they're typically scheduled for about a 1 hour BMO sessions where they're doing lower body cycling, and that could be continuous or with interval training. And then outside of dialysis, they're normally having therapy before their dialysis treatment. So they could have 2 sessions in the morning if they have, say, an 11 a.m. dialysis, or they might have 3 sessions throughout the day before a 3 p.m. dialysis session. So it's very variable, very individualized, if that helps answer your question.
Okay, thank you. And then there's another question, how long are the typical BMO sessions?
Oh, good.
Yeah, so we schedule it for about an hour. And again, the patient, it's individualized. So they're cycling for either that full hour or they're doing intervals and they're having appropriate rest breaks during it. But typically we're scheduling it for the hour to help with bringing the device to the patient, set up, breakdown, disinfecting, infection control, things like that.
Yeah, and I would say too, what someone had asked earlier, our rehabilitation aids are so key in providing these sessions to our patients because our BMO machine is stored on the ground floor and the machine has to go up to the first floor, so it has to ride the elevator. There's a little bit of traffic, it's always busy here, so our rehabilitation aids are so huge in helping us just get the devices up and down, clean, disinfected, really allowing the therapist to really provide that really, again, individualized and supervised therapy session during dialysis.
And then one of the last questions is, who provides the actual hemodialysis? Do you do that in-house or do you have a third party coming in for providing those services?
You want to answer?
Oh, yeah. So as Dr. O'Park talked about, they weighed the pros and cons to training our nursing staff to be able to provide hemodialysis versus going external with a third party, and ultimately we decided to go external to a third party. So we utilize Fresenius to deliver all of our hemodialysis treatments.
Okay.
Mm-hmm.
Thank you.
Yeah.
And I believe that was all of the questions we have. Nope, there's one more, the last one. You said that you're looking into potentially a second BEMO. Would you have a recommendation how many patients per device you can treat, or the other way around, how many devices you would need for a specific size of a patient program?
Yeah, right now, we feel kind of when we're busy and when there's a lot of potential dialysis patients who are appropriate for using the BEMO when they're here with us, we can provide typically on a Monday, Wednesday, and Friday, each of those days, 3 separate 1-hour BEMO sessions, just based on how the schedule is organized between how Fresenius is here with us providing actual dialysis and our staffing schedule, right, when our therapists are here. So right now, that's kind of our model, and we're limited to almost providing 3 sessions of BEMO a day. We could look at potentially expanding that maybe to a 4th session if we were to look at changing our therapists like lunch times, but we also value our therapists' work-life balance. So that's another conversation for another day. But having a second device would allow us potentially to have 6 patients every Monday, Wednesday, Friday who are on dialysis having BEMO sessions a day. So it would double what we can do now. And again, it's also very, individualized based on the person that's here and if it's appropriate for them to use.
And thinking outside of the dialysis program, the BEMO is great for patients who are on isolation, right? They can't leave their rooms for therapy, which is typically provided in the gym. So that's a nice therapeutic intervention that they can benefit from. Those patients who, maybe are quite low level. So it's a nice therapeutic device for them as well. So, it has benefits for, a variety of patient populations outside of those patients just receiving hemodialysis.
Do you want to add more to that?
No, I was going to just add what Sandra added. So, even if our hemodialysis census isn't so high that we have competing demands, there are other patients in the hospital that do benefit from it, upper and lower extremity cycling. So a hospital of we said 150 beds, like having one device, it gets used a lot. So a second one wouldn't be bad.
That's fine, somewhere to store it, but.
Yeah.
There's one more last question. Does the BEMO work unilaterally for those who can only use one limb? And can it be used for morbidly obese patients?
For one, it's so customizable that yes, you could use it for just one limb. You would just take off the other side component. And we have used it for and just making sure that it fits over the hospital bed.
Yeah, I believe when Brenda, who's one of the THERA-Trainer representatives who was here with us, she did tell us that the THERA-Trainer itself, the BEMO, does fit over a bariatric size bed, and I would have to triple check the weight limit. Frank, you might know off the top of your head, but I know we have used it for individuals who are of a different body habitus, a larger size, and it has worked well for us. But I don't remember the exact specifications of the weight limits, but Frank might know it.
Yeah, that was the last question, I believe, and I think we're also out of time. So with that, I really appreciate Burke Rehab and obviously the 4 of you for today's remarks and everybody who kind of signed up for today's webinar. And I wish you all a wonderful rest of the day, rest of the week. And with that, this webinar is concluded. Thank you very much.
Thank you so much.